Hi guys. So we're talking today about schizophrenia. You'll also hopefully already before you started this watched the two videos that I put up. One is a TED Talk by Ellen Sachs, and the other is a piece with Anderson Cooper in which she used a schizophrenia simulator. So if you haven't watched those yet, please stop this video, go back and watch those two. We'll also be talking about those two videos in detail in our first live discussion for this chapter. So make sure that you watch those. So the things I want you to think about when you watch those, or having watched those, if you've already watched those, is thinking about what your experience was of Ellen's interpersonal skills, and to pay attention and think about what you or how you reacted to her flow of ideas. And thinking about your textbook reading and what we're about to talk about with about schizophrenia, to think about what did you see or hear that indicated positive, negative, and disorganized symptoms that she has experienced in the past. So those are good things to hang on to. And then for the Anderson Cooper videos, I would love for you to think about kind of the difficulty he faced while he was using the simulator. So obviously he was hearing voices, so he was having auditory hallucinations or experiencing auditory hallucinations or simulated. But thinking about what things kind of unrelated to that, but because of that, that he struggled with, and then thinking about what might be hard in day-to-day life for anyone experiencing hallucinations. Okay, so we'll talk about more of those in the live class discussion, or you could also post about that on the Muddiest Points if you want. So let's just do an overview here. Schizophrenia is one of the most rare disorders that we'll talk about, not as rare as dissociative identity disorder, for example, but happening at about 1% prevalence rate, so 1 out of 100 people will get diagnosed with schizophrenia. And it's characterized by what is typically called psychotic symptoms. And being psychotic means essentially that you've lost touch with reality in one way or the other. And typically that means the presence of hallucinations or delusions. But as we'll talk about, there's also other kinds of symptoms that for some people are more prevalent than the hallucinations and delusions, and unfortunately those other symptoms are harder to treat. So we'll talk about that some as well. We'll also talk a lot about the fact that this is certainly the most heritable, the most genetic of the disorders that we'll talk about, though it's still not completely genetic. So let's talk about the types of symptoms that people with schizophrenia experience or might experience. And there's 3 general categories. The first is positive symptoms. And positive symptoms are essentially defined by something that is present that we would like not to be present, or that is not present in typical functioning. So positive symptoms essentially are hallucinations and delusions. Hallucinations are sensory experiences that are not based in reality, and that can happen on any of your 5 senses. So hearing and visual, so visual and auditory hallucinations are the most common, but you can also have taste hallucinations, scent hallucinations, and tactile hallucinations. And I'll give you some examples of that coming up. Negative symptoms are defined by the absence of something that is typically present. And so the inability to do something, or the absence of an ability that we normally have, and we'll talk about examples of those as well. And then disorganized symptoms are simply unexpected disruptions to behavior, so things that are not typical, and that also often indicate a disruption of task-oriented or linear kind of behaviors. So let's talk first about positive symptoms. Positive symptoms, right? Hallucinations and delusions. Hallucinations are those sensory experiences that we talked about. Delusions are beliefs that aren't based in reality. So let's try to give some examples or think about hallucinations for a minute. The most common by far hallucinations are auditory hallucinations, where we hear voices, followed by visual hallucinations, where you see things that aren't there. And those two really, and especially auditory hallucinations, make up the bulk of hallucinations for people with schizophrenia. But there are people who have hallucinations on the other senses. And at the very beginning of my career, actually, while I was still a student, I treated a woman, or was part of a treatment team, treating a woman who had a very complex hallucinatory system. And it involved auditory, well, it involved mostly visual hallucinations. She would see small people. And this started in her 20s, but continued through her adult life, and she was in her 50s, I think, when I met her. But she would see small people, but in addition, these small people would say horrible things to her. And that was the main hallucination. However, it actually was more complex, so that when a hallucinatory experience was about to begin for her, she would start by her being able to smell these people, these small people, and she would know that they were nearby, and soon she would see them, and they had a rank kind of odor. And then she would start seeing them, and then eventually hearing them say things to her. But eventually, as the hallucinations became stronger in any given episode, they would also get on her. They would crawl on her skin, and she would experience them biting her and scratching her, and so her skin would feel irritated and in pain. And then eventually, they would also get in her mouth and often make her vomit with the hallucination of the very bad taste that the hallucination brought with it. And so that's the more complex hallucinatory system that I've ever encountered, but it happened on all 5 of her senses. And the hallucination is important to point out, like all of us sometimes experience kind of an auditory version of our own thoughts. And that's not what auditory hallucinations are. The hallucination feels as if it's coming from outside of you. Your brain is processing information as if sound waves are coming into your ears or light into your eyes, and so that's an important distinction. Delusions are beliefs, so not these sensory experience anymore. They're beliefs. The most common for schizophrenia is certainly paranoid delusions, so delusions that people are trying to harm you, or delusions that the government is spying on you. I'm sorry. So I got interrupted by the dogs. So, the paranoid delusions that someone is trying to harm you, you're being eavesdropped on, the government is eavesdropping on you or sending you messages through the television, those kinds of things are delusions. There might also be delusions of grandeur here, similar to what we talked about with bipolar disorder, but without the rest of the bipolar symptoms. So delusions that I am Jesus Christ, for example, would be a delusion of grandeur. Negative symptoms, and I'm sorry, let's see, do this. Negative symptoms, again, are about the absence of something. So we have a list here. You'll see many of them, except for blunted affect, have an A in front of them, meaning without, right? So avolition, asociality, anhedonia, and alogia all are the absence of the things described there. I'm not going to read the slide to you. You can see that. Blunted affect is the absence of expressed emotion, and so we see somebody who might talk kind of in this way. So they're talking in a monotone and not really. They may be telling you that they had a birthday celebration, but you're seeing the absence of affect, right? And so even when they're telling you they're very upset or telling you they're very happy, that you're not seeing that. And as I said before, and we'll talk about more in the next lecture, positive symptoms respond to treatment, especially pharmaceutical treatment, medications, much more than negative symptoms do. Although we have some newer medications that help a little bit more with negative symptoms than the traditional medications have. All right, and then the third set of symptoms is disorganized symptoms. There's an example on page 255 that you can read, but this includes loose associations or loss of kind of logical progression of speech. Loose associations is I tell you that I like peas, and then so I say I like peas. I think world peace would be really important. I once had a piece of pizza, right? That kind of loose association where I'm kind of following something that's reminding me of other things, but it's not really logical in any way, and it's not task-focused speech. It's not speech that has a point at the end of it, and so I'm just kind of hopping from idea to idea with no real overarching organization of any kind. Disorganized behavior is strange or non-productive behaviors or repetitive behaviors, perhaps, or behaviors that apparently have no purpose of any kind. And we'll see people engage in those kinds of things. For example, at Connecticut Valley Hospital, they sometimes have problems with patients who do inserting. or eating strange objects, non-food objects. It's a real problem actually in terms of patient safety. But those would be examples of disorganized behavior. Might be inserting things onto your skin or into your nose or into your ear, other things. But again, without real purpose to it. Also, there are movement symptoms. Catatonia is probably the most commonly talked about movement symptom, where somebody really doesn't move much. Doesn't mean that they don't move at all, but they don't move much. And waxy flexibility is when you can put somebody's arm, for example, into this position as if they're made of wax, and they'll just hold it there after you let go. And there is a video here that you can watch that shows some examples of movement symptoms, and you can take a look at that. All right, so we're going to stop here. The next slide, next lecture is going to talk about etiology and treatment, starting with the idea of heritability and the both importance of heritability for schizophrenia and the limitations of it.